Hello and welcome. I'm Autumn Lafretta, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our panelists, I'd like to go over some housekeeping. Q&A. Please add your questions to the Q&A tool in Zoom. We will be recording this and the video will be available on the Foundation's YouTube channel in a few days. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. We would also like to thank our individual donors and our funding partners for making programs like this possible. I would also like to mention that tomorrow is Rare Disease Day. And we would ask that you please show your support for cutaneous lymphoma and post on social media your pictures and videos wearing stripes with the rare disease hands found here. You can use the hashtag or you can tag the Cutaneous Lymphoma Foundation. In an effort of global solidarity, you are invited to light or decorate your home with the Rare Disease Day colors at 7 p.m. your local time tomorrow, February 28th. For more information, you can visit the website listed on the screen. All right, now I would like to share some information on our speakers here today. I'd like to thank Dr. Okada and Dr. Ackerman for joining us. Dr. Okada is the Associate Professor of Medicine, School of Medicine, Oregon Health and Science Universities. Dr. Lindsay Ackerman is the Associate Professor, University of Arizona College of Medicine, Phoenix. So let's go ahead and get started. Welcome, Dr. Okada and Dr. Ackerman. Thank you for joining us today.
Thank you, Autumn, for the very nice invitation.
Yes.
Yeah. So before we start with our first question, oh, you're welcome. We're just so happy that you both can join us. We know you're very busy, and for those of us in the Eastern time zone, the doctors are not. They're graciously doing this for us on their lunch hour today. Before we start, I do want to go over one piece of information. A reminder that the doctors here are not giving a second opinion. They are sharing their knowledge based on the experience that they've seen in their own clinics. So when you hear their answers, please do not consider this a second opinion. If you have additional questions, please go see your own doctor. So now we can start with our first question, now that we got all of that out of the way. So our first question, are there any recommendations for how patients can actively support their overall health while undergoing treatment? And Dr. Okada, you want to start with this first?
Certainly. So the overall health is extremely important in this disease. As you're probably aware, this is a disease that, although we have lots of treatments that can help, many times this is a very long course of watching, treating, watching, and stuff like that. So the general overall health is important, but especially skin health. So keeping your skin in good shape, not scratching it all up, avoiding the sun, moisturizers, all those things can help keep the skin healthy, which keeps the disease more manageable and gives us more options to treat. So nothing specific for general health, but the better health you're in, the more options we have.
Yeah, I love Dr. Okada. Thank you for the shout out to skin health in general. And I'll comment as well that when we are managing somebody that has cutaneous lymphoma, I'll again emphasize what you mentioned, that this is usually the long game that we're on. We're looking for a long period of time in which to manage someone successfully, which will often mean going potentially from one treatment to even another at some point. So absolutely keeping your skin protected from the elements that otherwise may act poorly on your skin, like the sun, so that we have options available to us that may include phototherapy. If you are otherwise getting too much outdoor light, it may preclude us from utilizing phototherapy due to the additive or summative risk of UV toxicity. In addition, barrier control is exceedingly important. You mentioned, moisturizing and not scratching or excoriating at the skin, because patients that have cutaneous lymphoma also have a relatively sort of defunct or inadequate immune system in their skin. So these lymphocytes that have become cancerous were actually there to do something right. They were there for immunosurveillance, to make sure that we protect ourselves from infection in the skin. And with them not working well, you don't want to create any additional environmental impact on the skin that could also lead to infection, like scratching that happens after your barrier is maybe too dry and itchy. So giving yourself good skin health is really, really important. And then the only other piece of advice I generally make is that, and maybe more so for patients that have more consequential burdens of disease, but I generally think that an anti-inflammatory diet is a good choice. So, low sugar is usually a good thing for cancer. High sugar, usually a less good thing for cancer. And so I encourage, a low glycemic index diet in general.
Thank you both very much. We always do get questions about nutrition, so it's good additional information to have. So how do you balance the risk and benefits between phototherapy and skin cancer? So that one I would say Dr. Ackerman.
Yeah, sure. We have a phototherapy unit in our office. We can treat with both narrowband UVB and PUVA. So I have ample experience in managing this particular question and the risks thereof. With any given patient in any given moment, you're always sort of looking. I like to treat a person and not a disease state. So you've got to utilize the equation. If I have somebody who was, a swimmer and a lifeguard and spent their summers at the beach getting burnt, phototherapy may not be the right choice because the risk of them developing skin cancer in my unit, even though the risks are really, really low with the skin-directed therapies in the narrow band spectrum, it may be more than we want to assume. In other patients who really have been good photoprotectors all their life, narrowband UVB phototherapy is really a negligible emittance in what we would call carcinogenic wavelengths. So the narrowband UVB spectrum is just that. It's very narrow, and it doesn't actually emit ample amounts of light in cancer-causing wavelengths. PUVA is a little different. PUVA actually is a photosensitizer that is a combination of a pill you take followed by UVA light, and UVA light can be carcinogenic. And so we try to keep the total volume of treatment significantly reduced in patients that require PUVA. And there is a particular patient cohort that PUVA is a better choice for, namely those that have thicker disease or folliculocentric mycosis fungoides, because the UVA light wavelength is actually a longer wavelength, and so it can penetrate more deeply into the skin where the actual burden of the lymphocytes may reside.
All right, thank you. That was wonderful. Our next question, I have mycosis fungoides, which is often described as indolent. What should patients be watching for to know when to bring concerns to their doctor? So, Dr. Okada, you want to take the first pass?
Sure. So it is very patient specific. So a lot of it depends on the burden of disease. A lot of it depends on the type of lesion you have. The main thing is we don't want to let the skin get beat up from the disease where you're getting ulcerations, you're getting cracks, fissures. So keeping it under control there. And as you are probably aware, experience. Once you start getting to know your disease and how it behaves in different settings, you'll know, oh, this is behaving differently than it has in the past. I need to have them take a look at it, make sure it hasn't changed. So it is hard to give you a general how frequent you need to be seen, because it can vary quite a bit depending on both the disease, your familiarity with it, and somewhat what the physician's familiarity and comfort is. It is a rare disease, and some of our patients are being seen by people who only have one or two patients with this disease, so they get a little nervous too. So beyond that, I think is dependent on a number of different factors.
And I would just very simply add that itch tends to be oftentimes a symptom that's associated with the recrudescence of disease. And so if you've had really very limited disease burden, it's been indolent, it's been under fairly good control, and all of a sudden you're having a diffuse itch that just doesn't make sense even before any skin lesions would arise, that is something I think that's worthy of bringing to the attention of your physician.
Yeah. Or if the rash looks different, I think would be another big say, okay.
Absolutely. I'm sorry.
Go ahead. But it's good when we go back and forth, because you guys prompt thoughts from each other that you didn't think. So we're very casual here with our questions. So our next question is, for patients with CTCL-MF in stage 1A or 1B, are there research studies indicating that treatments with drugs like Bexarotene low and or prevents the progression, maybe slow and prevents the progression of the disease to more advanced stages compared to a wait and see approach. And Dr. Ackerman?
I'm happy to answer this. To my knowledge, there is not a prospective study looking at low volume disease burden. That means 1A, 1B, which is defined as less than 10% or greater than 10% of body surface area involved, and the prevention of patients progressing essentially while on Targretin or Bexarotene, excuse me. I think that's what was referenced. Sometimes it's more prudent necessarily than to assess what the literature says, even though I'm a huge believer in science. I don't want to be misunderstood, that we use our heads more than we use whatever's been yet to be defined scientifically. And by that, I mean we use our experiential, knowledge bank. We use maybe a phoning of a friend to ask that question from time to time. But it would seem logical that patients that have had more difficult to treat disease or higher burdens of disease have a higher volume of cancerous cells or have cells that are behaving more irreverently would be at potentially greater risk of an under-treatment protocol for taking an indolent disease into something that advances. And so in those particular patients, I do find that the more aggressive we are, it seems that the better that they do. And I hope that that answers the question.
Thank you. Our next question is, my main problem is how to deal with the patches when they flare up, as 2 of the patches are on the edge of my knee and inner thigh. These are rubbed by clothing. I'm assuming there's some itch involved and some discomfort.
I would ask that patient, what tools are you currently being given? I mean, there are a myriad of topicals that can be used on a cyclical basis, such as a topical corticosteroid at various different strengths, and you can use them with different dosing schedules. So sometimes it's twice a day for 2 consecutive weeks. Sometimes it's twice a day, Monday through Friday, with a break on weekends, and you might need to do that for 4 or 6 weeks. And then and that's kind of the chasing your tail. You use it when you need to, and you stop when you don't. And then there are other treatment options that are topical, what we call skin-directed therapies, that can be used sort of preventatively, that once you get disease under control, or even in the course to getting under control, you use something that you're then going to continue to use on a daily basis. That's not a steroid, doesn't have the side effects of potential chronic steroid use in the skin. And you can use that type of a topical, nitrogen mustard is a good example, where you can continue to use it long term, but maybe just infrequently for a maintenance of response. Once a week, twice a week, something like that.
All right, thank you so much. Next we have, after a mild case and it seems to be in remission, how often should the individual be checked? Is it really necessary to check every year?
I'll go ahead and take that. So again, it's a very individualized. It sounds like if it's a mild case, if you're very comfortable, one thing nice about this disease is that it is a disease you can see as well as we can see in the vast majority of the cases. The internal stuff, the blood counts, the lymph nodes, stuff that we do in the office in medical oncology, we don't see until usually later stages or more advanced disease. So what you see is what we're going to be examining. And so if you're comfortable of recognizing what is your disease and what's not your disease and how it's behaving, then the frequency can be as little as once a year. I think being more than once a year is a little more difficult just because it's harder to keep track of people that way. One other good way is to take pictures yourself. We oftentimes do it in our offices to help us remind ourselves what it looks like, but you can take your own photo journal and say, okay, yeah, that really is looking different, or it's getting worse, or it's involving more skin. So I think once a year is kind of our minimum, but there are some patients who have very little disease. They get very comfortable with that, and they do a good job of managing it themselves. So it all partly depends on the patient.
Mm-hmm.
All right, thank you. Are there any new treatments on the horizon for Sezary syndrome? I know that there's different ones, but I'm not sure who wants to tackle this one.
Sure. There certainly are. I'm happy to take a first stab at it. I know of several clinical trials that are actually ongoing. It's so nice to have a lot of interest by industry in really moving the needle in what we have available to us for our Sezary population, a very challenging disease to treat. So there are combination therapies in trial right now, looking at existing medications and new modalities to use them, like mogamulizumab or poteligeo, in combination with extracorporeal photopheresis. There's another trial that company is pursuing with mogamulizumab in combination with total skin electron beam radiation, low dose. There are some other drugs that are used, and Dr. Okada, I'm sure you could speak more eloquently to this than I, but used for other diseases. CLL, I think there's alemtuzumab who's being studied now for Sezary patients. And there are new molecules also being developed for the Sezary patient population as well. One thing you can do, rather than maybe giving you the answer today, because it could change tomorrow, is you can go to clinicaltrials.gov. It does not require any subscription, and you can actually search the word Sezary in the disease state and see at any point in time what's available. Sometimes it's, maybe teaching you how to fish and not necessarily just handing you the fish, because this is going to be, I hope for many of you, a long process. And looking at what's available at any given point in time through clinicaltrials.gov could be a good resource.
Yes, I would certainly also echo the clinicaltrials.gov. It also gives you regions so you can see if there's something local that has clinical trials. The other big things that are really coming through for this disease or advanced stage CTCL is the trying to find a good target that we can use what they call CAR-T immunotherapy, where you take your immune cells and target the tumor cells. The other big immunotherapy approach is to use something called a bispecific antibody. So we're working with a company, Ono, who has a CD3, which targets T cells, and PD1, which targets the tumor cells, to see, again, can we use the patient's own immune system to try to attack the tumor cells. And as mentioned, we do have small molecule inhibitors that work on the signaling pathway within these tumor cells, that if you interrupt the signaling pathway, the tumor cells die. So we have one with Corvus that is looking at these small molecule inhibitors, and there's a number of them. So what you can tell is we're moving away from chemotherapy as the basis to try to kill tumor cells. We've done a lot of work with chemotherapy, and especially Sezary, it has been very difficult. But using immune cells, using small molecule inhibitors. The other one is a new one is trying to use JAK inhibitors because that's an altered pathway in these tumor cells. And so, again, if you stop the signaling, the cells die, or we can slow it down. So there is some good progress being made. As you're all aware, this is not the most common disease, and that's where we really struggle. Lots of good ideas to think about and try, but trying to get this looked at in a clinical trial to see, is this really helpful, is difficulty of getting patients on these studies to see. Because we just don't see, the incidence of cutaneous T-cell lymphoma is about 6 per million per year. So to get enough patients where you can actually evaluate, is this really helpful or not, takes a long time. And the other thing is that even Sezary, there are some Sezary patients who just really struggle, and others respond pretty well to treatment. So that also makes the study of this disease particularly difficult. But we're making some progress using different approaches, and I think that will help.
Dr. Okada, may I ask you a question on that note? I mean, clearly you're saying something that's really important for I think our audience to understand, and that is, I don't think it's by lack of interest. I think it's really because to get the volume of patients where you can show a statistical benefit is a challenge. I want to just emphasize, all of these clinical trials we're referencing are not a clinical trial that would either give you drug or give you placebo. It would give you drug versus a standard of care. So if hearing the word trial makes you nervous because you think you might get randomized into a population of patients that get nothing, that would not be this type of trial. There's always going to be an active agent administered. And I think it's really great to be able to contribute to both getting potentially novel therapy, but contribute to the science of helping the population that really does struggle with this rare disease.
I really appreciate you adding that piece, because I think especially if it's someone that's newer diagnosed and aren't familiar with clinical trials, everything you hear in most clinical trials is there's always a group that does not get it. And when I first learned about what we do with cutaneous lymphoma trials, that was something that stood out to me. Everyone gets treated. It's more tracking, is it doing something? So thank you for adding that. I really appreciate it. The foundation also does have clinical trial information on the website and a link to clinicaltrials.gov. So if you're utilizing the foundation's website regularly, there is a section on there too. So, all right, let's go to our next question. That was great information. So we have a nurse who performs extracorporeal photopheresis, and they're asking, is there a way we can best support our patients who are new to ECP, especially with adjusting to frequency of visits and maintaining systems through the first few weeks while we get treatment started?
Yeah, so that is a treatment that we very much like, partly because once they get going, it's extremely well tolerated. It doesn't have the side effects of chemo. We have some pretty good pheresis ports, so the big needles that we otherwise need to use can potentially be avoided. And so patients tolerate it really pretty well once they get going. The efficacy, how well it works, is decent, I would say. There's certainly patients who don't respond. The unfortunate thing is it does take a while before you can tell, is it going to help or not. The median time to response, meaning at least 50% improvement in the disease, usually skin, but also circulating, is somewhere around 4 months, 2 to 4 months before you can say, is this really going to help or not? We do sometimes use adjuvant agents to that, interferon or Bexarotene, to see if we can make it better. It is difficult for these patients, so getting them set up to do the pheresis if they need to get a port, especially if their skin is bad, then ports are not a great idea. What do? We oftentimes use oral steroids as a bridging kind of short-term thing. Long-term oral steroids are not a great way to control this disease, because once you get on lower doses of steroids, it comes right back. But for short-term, get some control, get them some relief of the itching, and get their skin a little healthier. It's a good short-term thing, but that's probably my main go-to thing before they can get going with the photopheresis, and even potentially overlapping a little bit until photopheresis has a chance to work.
I agree. We use a lot of ECP as well, and I also think it works really well in combination with other things. It doesn't have to be high dose other things, but oftentimes using it in combination, even with skin-directed therapies like narrowband phototherapy, or Bexarotene, or even methotrexate. Sometimes I get patients under control with a bridge of methotrexate, and then I withdraw it once they're doing well. And steroids, of course, topically and systemically.
All right, thank you both. Next, we have someone that's been doing some reading online. They were diagnosed with mycosis fungoides, and they actually have FMF. And they want to know, are there other benign skin conditions that can show T cell? And they're also looking at and they look very similar under the microscope. They want to know, how do doctors confidently diagnose MF versus something else? Their lesions come and go on their own, which they understand to not be typical of FMF. And I have a follicular tropic mycosis fungoides. I sometimes have a hard time with that word.
I mean, I'll tell you, diagnostically, the clinical question that's presented is a challenging one. It has happened to me on a couple of occasions in my career where I've had someone clearly be able to identify that the waxing and waning of their skin lesions is actually like spontaneous, and these skin lesions are not of the category that we would otherwise assign to lymphomatoid papulosis, which would be another T cell dyscrasia, atypical behavior of T cells, not a malignancy by classification, and yet it does tend to wax and wane on its own. So these are patients, a couple patients that have had plaque disease that looks just like MF, that on biopsy says this is MF, in fact, follicular MF even, where they're telling me that these plaques come and go on their own. It's an unusual situation. I will tell you that monoclonality in an inflammatory disease is very rare, and very, very rare in young people. Where we start to get monoclonality in otherwise benign conditions. And I'll have Dr. Okada comment on this, please, as well. But my understanding is we do, and we see this on occasion in elderly adults, they can have T cell clones in their blood that are really inconsequential whatsoever. But to have clonality in your skin, and to have plaques that clinically look like mycosis fungoides, follicular mycosis fungoides in this case, which under the microscope also have the phenotypic changes one would expect, histologic changes of the T cells themselves, meaning the morphology, the shape, the size, the arrangement architecturally of how these cells are aligning next to one another, that's also compatible with follicular MF and clonality. I would find it very difficult to take any other diagnosis into serious consideration other than it being MF.
Okay. The other thing I would say is that one of the strategies that we use to try to get a better appreciation, is this a malignancy or is this a reactive condition? We will oftentimes do 2 biopsies at different parts of the body, with the thinking that if it's reactive, you should not see the same clone of T cells in 2 different places. Even better would be doing 2 biopsies, 2 places with a interval of time between those 2. We do not expect reactive T cells to be hanging around for a period of time and then being found at the other 2 sites. Finding the clonal T cell population in any of these biopsies is not diagnostic for a T cell malignancy. There are reactive, very often we see reactive T cell populations that we can see the signal, this clonal T cell population. So it is helpful in putting it in, as Dr. Ackerman said, in context of the way it looks under the microscope, whether there's any changes in the proteins that are expressed on these. We call immunophenotype if there are abnormalities there. But they all go to support, and you'll see sometimes in the pathology report, they'll say, they use codes. They say, looks like it's suspicious for mycosis fungoides. It is consistent with mycosis fungoides. And then if they're sure about it, then they say it's consonant, or they're sure this is mycosis fungoides. And that's by putting all these pieces of information together. So the clinical is a different thing as well. So even though it may look underneath the microscope to me, MF, and the diagnostics all point that way, we treat your disease and the way it's behaving. So where if your disease waxes and wanes, one model is that your immune system is interacting with these clonal T cells, or this tumor, cancer, lymphoma. And sometimes it gets the upper hand on it and the lesions recede, and sometimes these figure a way to avoid the immune system and they progress. So it can vary a little bit in that regard as well. So managing the disease is not only based on the title or the label we put on it, but how it's behaving in you.
I think that's actually a really important comment. And forgive me, you clarified. I actually had made the assumption that when the question was asked that clonality had been proven, I assumed it was 2 sites and actually with a time interval as well for another test. We don't take clonality as diagnostic on a single event. Clonality really needs to be proven by virtue of matching clones in 2 distinct sites at the same time, or the same clone with a timeline in between that clone is persisting. And you're absolutely right. In those couple of patients I've had that describe, again, this patch plaque presentation that looks just like MF, that waxes and wanes and kind of goes away and comes back. The only explanation I could really give, and this isn't necessarily through any proven scientific experiment, is that, thank God for their good immune system that's trying to attack this over and over again. And sometimes it'll win and sometimes it may not, but we just have to treat them, at whatever point in their disease course they are.
It was wonderful answers to that question. That was a little more complex one. I appreciate you both breaking it down. So our next question is from someone in the UK, and their dermatologist did recommend mustard treatment, but they read the instructions and it put them off. So in the UK right now, standard for 1A is a 6-monthly review and an annual blood test. So I believe the question in here is, what has your experience been with mustard treatment with your patients? And is it something that you have, what are the benefits that you've seen with it, if you have seen benefits?
I'll be quick. I used a lot of nitrogen mustard in training. We used to compound it in a pound of aquaphor. I would go in as a resident and see the patients before the attending, and they would complain and complain and complain that they hated it and they hated smearing themselves in this grease and they couldn't get dressed and they couldn't touch anything and life was miserable. And then the attending physician would walk in and of course he'd be like, "Oh, I'm just fine. Everything's fine." And yeah, no, here I reported they don't like their treatment. And anyway, I really fell out of favor in treating with nitrogen mustard once I had graduated from my residency and I was no longer forced to compound it in aquaphor for patients because I just found that the experience for the patient was probably suboptimal. And there were other things. But fast forward when we have now been in the United States, given the opportunity to use mechlorethamine compounded in a gel formulation, which seems to be much more well tolerated, I have fallen back in favor of using nitrogen mustard as a treatment option. They have actually exceptional data that really shows that there's no systemic absorption with high volume use in patients that required nearly full body treatment, full body surface area treatment daily for upwards of 6 weeks, did blood tests, didn't find any nitrogen mustard in the blood or any nitrogen mustard metabolites in the blood. So I don't believe it in this formulation to be systemically absorbed. I think it's safe. It does take a little bit of time to get tolerant to it. So I don't start it every day right off the bat in everyone. I start slowly, work up. But I have found success with it. Now, 1A disease, again, it is a big range. There's a big difference between having a plaque or a patch that's a half of a hand, 1/2 of 1% on your body, to having 10% on your body. And the symptoms that go along with that are also probably quite different. And I said I would say a short answer, maybe not so short. I'll hand it over, but really 1A disease can be broad, so you have to treat the patient where they are.
I think that even though it wasn't short, it was really helpful. And as with being a patient in the UK, they may not have the same formulations that we have. So knowing the experience, that's really good. Right, and our next question is, for someone who has FMF and has tried several therapies like Bexarotene, what are your thoughts on long-term use of total electron beam therapy? What are the common side effects?
So we actually like total skin electron beam therapy for this disease. As mentioned earlier, the lymphocytes that are involved in the malignancy here go actually quite deep into the skin. So the surface stuff, the topical steroids, even nitrogen mustard, PUVA, sometimes don't get deep enough into it, and so the disease keeps persisting. The downside of electron beam therapy is that it's pretty intense. It is... you have to, in order to make sure you get uniform exposure to all the skin, you have to be able to sit and hold a position, I think it's 23 different positions where they give the treatment. It is tiring. It is daily. We are using the quote low dose 10 gray total body that has been developed or pioneered by Rich Hoppy at Stanford. And so it is 10 days of treatment. And so it does get tiring. It's not uncommon, especially for sensitive skin, to feel a little bit burned afterward. And so dealing with the skin irritation of that. But it is incredibly effective. The overall response rate is 90+%. So we do see significant improvement, if not complete resolution. And so we do like it for the follicular tropic MF, especially because a lot of the other stuff, not that it works better in follicular tropic, it's just the other stuff doesn't work as well. A few other things that we will sometimes see is loss of sweat. So people can have some temperature regulations until the sweat glands regenerate, so wearing layers. There is a slight increase development of cataracts, because of the radiation that hits the lenses. And maybe Dr. Ackerman, there is a little bit, but not a tremendous amount of increased risk of getting skin cancers from this type of treatment.
Yeah, I would say the bigger, more relevant piece is that patients need to know that they could expect changes in both their nails and their hair. Lose their hair, they can lose, a bit of their nails, or have, changes in their nails that are significant where the plate does not adhere as well to the bed. with total skin. But I love total skin. It's a great treatment option for those that really do need it.
Yeah, but unfortunately, it's not available and most places don't do it. So if there is a place that is close, like our center does do it, and we have people traveling, all the way from Washington, and they will stay for the 10 days for the treatment and get it, or 2 weeks basically. But check with your dermatologist or medical oncologist and see where they are able to do it. And it's mostly experience of the radiation oncologist to know how to do it.
Yeah, and we're talking very much about follicular MF, but please know you can use total skin electron beam in other forms of MF, from plaques to those that have blood involvement. In fact, the symptom relief that can be achieved with total skin is actually quite high. So sometimes we'll use that too as a bridge. When we're thinking about ECP to manage their blood, we may decrease their skin volume by attacking with total skin first, and then moving on to ECP.
Right, thank you. And thank you for that reminder that it is usable for other types of MF. Have you seen if MF affects fertility? I've had MF since I was 5 years old, and I've had it at stage 1A for decades. Before the doctors answer, we do have a section on the website where we have a PDF that links to medications for CTCL that could affect fertility, and it talks about both for male and female. So there is some information on that.
That's really important, Autumn, actually, because this tends to be sort of disregarded as a disease that preferentially, is a disease that affects the elderly. We don't talk about those things, but it's great. It is a great resource on your website that for those that would be in childbearing times of their life to consider. I'll just answer the question by saying no. I am not aware of MF having any impact on fertility.
Okay, thank you. Our next is, do oral Bexarotene and topical Bexarotene have the same systemic side effects like hyperlipidemia? Is one better than the other? Sorry. My very first one I did of these, Moga maluzumab came up, and I could not, I tripped over it. And then luckily one of the clinicians was like, just say Moga. That's what we say.
Just say Moga, yeah.
Yeah.
So this answer.
Yeah, obviously, if you're taking a pill, your whole body gets exposed to that drug, you're going to have much more side effects. The topical, you'd get very little absorbed through the skin into the blood. You don't see the hyperlipidemia. You don't see the central hypothyroidism. You do get dry skin from it, but you don't see nearly the side effects. So it is thought to be a much safer way to deliver Bexarotene if you have limited skin disease. It's one of those expensive medicines, so you can't be slathering it all over if you have a lot of disease. But it is much safer to give it topically if that works.
Okay,
I like to say it's good
for
skin. I was going to say, I like to say it's good for skin limited disease, meaning topical is not going to be used if you have blood involvement, right? Unless, of course, you're using it with something else. So it's good for skin limited disease. It's also good for limited skin disease for the reasons that Dr. Okada just mentioned, is you can't smear that expensive stuff over everything because you'd be out of it and broke both shortly. Yeah.
Oh, I like that. I'm gonna re-listen to that and make a note of it on the recording. That's a good one. How long should one continue taking oral Bexarotene, and does it lose its effectiveness over time?
Yeah, we have not seen a cumulative toxicity with Bexarotene directly. Again, if it's low dose, we don't usually run into a lot of lipid issues. The triglycerides we sometimes see with this is not usually a big problem, but indirectly, meaning elevated LDL, things like that, can lead to early or atherosclerotic disease or peripheral vascular disease. We're not sure if you use the low dose, whether you lose the efficacy with long-term use. It has not been well studied that way. And so I can't tell you if, quote, you're using your good treatment early by using the low dose and for a long period of time, but I know some people do, and I have not heard of. I'm not sure that there's good data to support that it loses efficacy, but eventually one would expect your disease to break through that.
All right, thank you. How often does a patient on Moga infusion need additional therapies? What are some options to add? How long is Moga likely to work for Sezary before moving to a new therapy? So if we can pop the question back up as the doctor is answering, since there's 3 different questions in one, that way we can make sure we address it all.
So the first part of it, need additional therapy, is a little hard. The way Moga was studied was a single agent. So when they did the study, it was just using it by itself. So the addition, as Dr. Ackerman told you at the very beginning, we're doing some combinational studies where are using mogamulizumab with a targetin, or using it with ECP, or using it with light therapy. So in a clinical trial setting where we actually know how much these different things add to mogamulizumab, we don't have the answer yet. We may in a few years, but we don't have that. So it makes sense to add an active drug with another active drug, but again, how much it adds just gets to be hard to determine. The median duration of response with mogamulizumab is about 10 months. That means the time where you've got your maximum response to when the disease starts progressing. And we have clinical definitions of all that thing, but it's about 10 months. Doesn't mean that you immediately need to start treating your disease, but that's when we start seeing the disease progress from your best response. This is a drug that is given intravenously, so it is very good about clearing what we call compartments. So it's very good about clearing the blood compartment. It does a good job of clearing the skin compartment, so those are 2 major areas where we'd like to get the disease out. The lymph node responses have been slower, so this response rate that you hear with Moga, it's not higher, mostly because it's not as effective for a disease that's in the lymph glands. So the people who have Sezary with more involvement in the lymph gland, it does again make sense to try to add something, but what to choose and how much you're adding is yet to be figured out.
Yeah. And there's a comment on that as well that, Moga clears the blood before the skin. And so for those that might be on Moga, to not be hesitant to ask your doctor for other things that maybe if your skin disease compartment is very symptomatic and life-altering, at times even, that we can, even though it's considered off-label, we can use our discretion and help to assist you with something in addition to Moga if necessary. I think the average time to get about a 50% improvement in skin on Moga is just over 3 months. To get blood response is only a month. So you're still lingering with your itch and discomfort, and can certainly use other things.
Okay, thank you. I'm going to do a quick time check. We're down to the last 15 minutes. So if you have any questions, if you want to make sure you get them into the chat, into the Q&A, so that we can get the doctors to ask as many as we can get done. So can you discuss the pros and cons of treatment options for MF like Moga, which we've touched a little bit, but vorinostat and any other treatments for FMF?
I think we hit a little bit on this when we were talking about phototherapy earlier, because for many follicular MF patients, if it's not scalp where the hair would block, the phototherapy from coming onto the surface, that's an option. And then we talked about total skin electron beam, another skin-directed therapy. Bexarotene is another, which is known as targetin, the oral agent we've talked about, which does have, sort of a requisite downside of causing central hypothyroidism and probable hyperlipidemia, usually hypertriglyceridemia, but things that we otherwise can also monitor and manage. And then, I can leave to Dr. Okada more of the cancer-directed, vorinostat, the histone deacetylase inhibitor class, which tends to have more side effects along the cell lines with cytopenias and potential liver inflammation and so forth. But there are many options in summary, both skin-directed and systemic for follicular MF. It is a more challenging type of MF to treat, but there are many options.
And so, as Dr. Ackerman suggested, for systemic options, we don't think of follicular tropic MF to be a more difficult subtype of mycosis fungoides because the systemic nature of the delivery. The exception being we do find the retinoids to be more effective than a lot of the other stuff. So the Bexarotene, I don't, but I know my dermatology colleagues use a lot of Accutane or isotretinoin, partly because that's what they use for their acne type stuff and they're very familiar with it. But using some of the retinoids tend to be a little more active in follicular tropic than we might otherwise typically see. Especially if they're associated with the gland issues and they get the infections and things like that. But for like vorinostat, it is the drug that's hard to use, not because of biological changes in the blood or anything like that. It just makes people tired. It gives people funny tastes in their mouth and they lose their appetite. So each of these things, and unfortunately, we have a guidelines called the NCCN guidelines, and I don't find it a useful tool just because I hate to say it, but when we get to systemic therapy, it gets a little bit of trial and error. I don't have a good way to necessarily say, oh, for that follicular tropic, this is the systemic agent we use first, and that's the one we use second, that's the one we use third. It is a balance between side effects, how much disease, and what has worked. So we don't have something that's a stellar, this is your, the frontline therapy, systemic therapy. So it makes it hard. And that's where, unfortunately, the experience of whoever's treating you can play a big role. What we do note is that, and most people would agree, we try to stay away from combinational chemotherapy regimens. I have seen some patients who get treated with a regimen called CHOP, and most find that although it's very effective, you use all your good drugs all at once and end up running into problems later on. So we try very much to use single agent regimens, which is different than almost the other types of lymphoma we treat. Gemcitabine, very effective. The mogamulizumab, the vorinostat, romidepsin, pralotrexate, all those things are very active, but again, trying to figure out what's the right one for a particular patient does take experience that's different from one patient to another.
Thank you both. And something that I thought of while you were answering that typically comes up in almost every one of these that we do is, if you've seen one patient, you've seen one patient. Every patient is unique, so that the trying the different combinations will work for one and may not work for the other. And I think for especially someone newly diagnosed that hasn't met anyone else that has cutaneous lymphoma, everyone is unique, and your doctor is going to be the best person to help you through that process. So, all right, let's go to our next question. I think we're going to have time to get to these next three, which rapid fire came in as soon as I said we were running low on time. Is it normal for MS spots to get worse in the sun? My rash flares up after the sun, but a few days later will dry out and look better than before. Dr. Ackerman?
Interesting. So I can say that we see this sometimes with phototherapy also. It's not across the board. And I wonder if it could be also heat, because I've had a lot of patients say too that it's not necessarily when they're in the sun, but when they're in the heat that their disease gets more visible. Heat can certainly make the disease more visible because when you vasodilate, you can bring more tumor cells to the surface, but also you just bring everything that's pink and make it a little bit more pinker in the skin. So if your skin tone tends to be fair and your disease is presenting as pink, patches or plaques, then that might increase the presentation. From the perspective of actual sun hitting you, regardless of the outdoor temperature, it might make sense that you're actually killing off some of the bad T cells. And in so doing, your good cell milieu comes in and cleans up the garbage of those bad cells dying off. So that might also on fairer skin look a little bit more visible. Now, in deeply pigmented skin, and this is a disease that we see more commonly actually amongst African Americans, and in the African American population is more common, I should say, than in the Caucasian population. Disease that is hit by sun will look darker. And that is a pigment phenomenon that has to do with the amount of essentially melanin production by the melanocytes in more deeply pigmented skin types than the type of and degree of melanin that's synthesized by those that are Caucasian. So sun can induce what we call hyperpigmentation, making it more dark, but not increasing the disease burden.
All right, thank you. And we had a patient that popped in a comment. She said that my MF has helped so much by sunlight and cold water swimming. So could you get any feedback on the cold water swimming aspect? It's the first time I've heard that, but I am not.
That's a little harder to explain. I mean, we usually describe the distribution of early stage disease as a bathing suit distribution, and the thinking there, that's the area that's most shielded from the sun. I'm up in Portland. We never see the sun anyway, so we don't see so much variation in season. I'm sure Dr. Ackerman sees a little more variation, but it's not uncommon for patients to say during the summer months they have less problems with their disease. The cold, I don't know.
All I can think
she added that it's salt water. She added that it's salt water. So
I wouldn't argue with her personal evidence. I just don't know. I don't have a good scientific answer.
Okay, thank you. All right, I think that we'll be able to get two more questions in. How does anemia affect MF, if at all? Have either of you had experience with that?
Yeah, not directly. I have not seen any correlation to severity of disease and severity of anemia, meaning people who are more anemic have worse disease. The only thing that I could think of is if somebody is iron deficient, and that's the reason for the anemia. The iron deficiency may influence how the skin is behaving. So that's the only kind of correlation I could see between anemia and the way that the mycosis fungoides is behaving.
Yeah, and the only other, limitation with that is that, some systemic therapies may be contraindicated if someone has underlying anemia from drug toxicity standpoint.
Okay, thank you. And this will be our last question for today. Is my white blood cell has always been slightly low and my LDH low. Could that be related to MF? And remember, this is just an experience. If they've had patients with similar type of levels that the doctors can provide a response on. And you can see they're both thinking it through.
I mean, patients that sit with low white counts, that's their normal. Have I ever had a patient who has MF who happens to sit with their normal being a little lower than the lower limit of normal on a test? Sure. I have also psoriasis patients and patients that have, a history of basal cell carcinoma that also sit with a white count slightly below normal. I don't directly believe it is related in any way to their MF, but I'll defer. That's just my experience.
The other major issue is there are 5-6 different types of white cells. So the low white cell count may actually be lymphodepletion or low lymphocyte counts, and that may give you a slightly low. And that could be influenced by cutaneous T-cell lymphoma. The LDH being low is actually good. That's a non-specific enzyme that's found in all cells, and so the more cell turnover you have, the more LDH that gets released into the blood and picked up. So that's actually good to have low LDH as a marker for your disease, but it's not very specific. Lots of things can alter that.
Okay, I want to say thank you both for coming today and taking your generous time to answer all these questions for the patients. We have this unique opportunity. They can ask them live, and they really appreciate that one. And I want to thank everyone for attending today's webinar. A quick reminder to please fill out the survey that pops up. It helps us know if we're doing well. And I would want to ask the doctors if they have any parting thoughts they'd like to share with us before we close out.
I would say kudos to you all for just being here, for recognizing that there are opportunities that you can take, whether you're acting on behalf of yourself or for someone that you love. There's always a movement that, might just be the answer to a question you're looking for, whether it's new scientific advents in therapy or just understanding what else some other doctor may have done for their patients or seen before. So kudos to you for wanting to learn. It's a privilege, certainly, to have the opportunity to treat patients with MF and Sezary syndrome and to work with other exceptional oncologists and subspecialists in treating the disease. I love my job. I'm so grateful to get to do it. And I just say thanks for your attention.
And we are so very grateful for you joining us today.
And I just want to extend a extreme gratitude for the Cutaneous Lymphoma Foundation. This is a rare disease. Finding good, reliable, accurate information is difficult when you do a web search. And this organization has provided not only information, but allowing people to get it in contact with other patients who have this disease, a valuable resource for a lot of other things that is important for patients who have mycosis fungoides and other cutaneous T-cell lymphomas.
Yeah, the Cutaneous Lymphoma Foundation, hands down, has done so much for giving visibility to what otherwise is just an incredibly difficult disease to find, meaningful, reliable information on, given its rarity and joining people together. Huge thanks to the CLF.
And we appreciate that. And we can't do it without you, because that's where our information comes from. So thank you both again. And thank you again, everyone, for joining. We hope to see you at a future program, and have a great rest of your day.